great, but you don't want to miss the cardiovascular problems that are caused by sleep apnea, which produces endothelial dysfunction, oxidative stress, pro-inflammatory states. And just for the record, Johns Hopkins researcher, clinical expert John Samet said untreated sleep apnea is the equivalent of smoking a pack of cigarettes a day. So if you want to smoke a pack of cigarettes a day, don't treat sleep apnea.
That's quite an endorsing statement. Hello, everyone, and welcome to Finding Your Wellness, a podcast sponsored by the Columbia Association. I'm Dr. Harry Oken, a community physician for over 37 years, and I'm proud to be working with CA for over a decade to help assist in their mission to improve the health and wellness of our community. Sleep is one of the 4 pillars of good health that supports our immune system. The other pillars are good nutrition, regular exercise, and stress control. These 4 pillars hold up our immune system, which controls and fights inflammation, which is the basis for most illness. We spend about a quarter of our lives sleeping, so we should get it right. And to help us get it right is an old friend from medical school. I want to introduce Dr. Barry Krakow. Barry is a board-certified internist and sleep medicine specialist. He's internationally recognized for the discovery and implementation of the most advanced approaches to solving the disabling sleep problems experienced in mental illness. His new book, Life-Saving Sleep: New Horizons in Mental Health Treatment, opens up a revolutionary system for treating mental health disorders by targeting the underlying sleep dysfunction. We're going to talk about that today. His work appears in leading scientific journals, including The Lancet, JAMA, the American Journal of Psychiatry. His TED's talk on insomnia has gained 750,000 views and is the most popular discourse by practicing clinical sleep medicine specialists. In the past 20 years, Barry has been interviewed or appeared on hundreds of media outlets, including feature presentations on ABC 2020 and ABC Primetime, as well as featured works in Time Magazine and The New Yorker. Gosh, you've done a lot. And it all started at University of Maryland Medical School. You and me
Indeed.
And 2 other people.
Indeed.
Welcome, Barry.
Indeed.
It's great to have you. So
thanks. First time ever somebody pronounced my first and last name correctly.
How about
Way
that?
to go, Harry.
Well, this is a joy to do podcasting, particularly with old friends, and find out what they're doing and share their views and learn. So it's great. It's great to have you here. I want to sort of kick this off by saying to you that when I ask my patients how they're sleeping, which I do regularly, how are you sleeping? And we go over sleep hygiene. I would say 50 to 60% of my patients tell me they don't get good sleep. They could sleep better. And I think most of us feel that way. We could sleep better. So let's just start off that discussion with your comments about that.
Well, it's great that you asked the question that way, because so many people are more likely to answer that question, if not phrased correctly. I don't get enough sleep. So lots of people with sleep problems are more fixated on the number of hours, thinking that equates to the concept of better sleep, when in fact it does not. Better sleep is a physiological process. So that means the reason all these people are answering your question the way they are is that something is not going well with their sleep physiology.
Got it. So let's go over the usual things that we talk about, and then we're going to talk about more advanced ideas and concepts. So, when we tell people about improving their sleep, we usually go through a whole variety of simple things that people can do,
So let me interject something on that. I have another book coming out tomorrow. It's called Fast Asleep: Advanced Guide for Sleep Hygiene. The reason the book was written is because so many people fail sleep hygiene steps. Most people don't seem to understand that There's all this stuff that comes out in the media. Many healthcare professionals may present sleep hygiene as a very important set of tools, and it can be. But I'll go back to what I said first. If you don't have sleep physiology corrected, when you try to do sleep hygiene, you're actually potentially about to make things worse. So, yes, there are individual items of sleep hygiene that can work. Obviously, you don't drink caffeine after dinner, something like that. And there's a number of things you can try, like trying to, get up in the morning at the same time. But I will say again, if you haven't fixed sleep physiology and you get somebody going down those steps, you're going to immediately find a whole number of people who don't get any benefit. And you're going, well, why did that happen? I thought sleep hygiene is supposed to work. The sleep hygiene book that I wrote comes out tomorrow called Fast Asleep, combines sleep hygiene with cognitive behavioral therapy for insomnia, which is a much more advanced psychological set of tools for the treatment of the specific condition known as insomnia. And then near the end of this new book, I talk a little bit about the sleep physiology part, which of course is covered more in depth in the life-saving sleep book you mentioned at the outset.
All right. Well, let's go through the ordinary list and get your comments on things. Okay. You
Sure.
mentioned about caffeine. Okay. And caffeine has a half-life of, depending on the person, between 6 hours and 12 hours. So when we talk about, for our viewers, when we talk about half-life, if you take in 100 milligrams of caffeine, which is a standard kind of strong cup of caffeine, and you have a half-life of 6 hours, 6 hours later, there'll be 50 milligrams of caffeine in your body. 6 hours after that, there'll be 25. So it's really important for people who are slow metabolizers of caffeine to not get much caffeine, after noon for many people, because that will affect your sleep. So caffeine.
Don't look at it that way. I don't look at it that way at all.
Tell me how
And
you.
the reason is you never know me to be obsessive or anything, right, Harry? Um, I almost never will start with my patients. Now, remember, my patients might be different what you see in general practice. I'm dealing with mental health patients almost all the time with complex sleep problems and mental health problems. When they're talking to me about caffeine, there's two things I'm concerned about. One, is this a tool that's actually helping them function during the day? Because if it is, I want them to use it. But much more importantly, many people use caffeine to be safe drivers, safe workers. All kinds of people have had their lives saved by using caffeine. So that's why I say here's an example of sleep hygiene where I don't go down that pathway. Yes, I mentioned it. And yes, somebody who's drinking it late in the afternoon is going to have a problem. But I never go into the detail you're talking about. I want to know personally tailored medicine, patient-centric medicine. What is this patient doing with the caffeine? Those are the questions I need to know before I can make any kind of recommendation. And often I'll say, don't touch your caffeine. Do whatever you're doing with your caffeine. Let's talk about that in a month. I want to deal with something else first, like sleep physiology.
Okay. All right, let's talk about a few other things, just so that people know they want to sleep in a comfortable environment, right? Best
Absolutely.
temperature to sleep at.
Well, we know for certain that if you put your bedroom at 55 degrees Fahrenheit, the chances that you're going to get your absolute best breathing are the highest at that temperature. That's been scientifically proven. So you will find a lot of people who are savvy about their sleep know they have to be in a cooler bedroom. But here's where it gets very confusing. If you're an insomniac, you suffer from vasoconstriction in your hands and feet with anxiety and tension, especially later in the evening. And so you now are cold. So you want blankets. You want a warmer bedroom. Then you vasodilate a couple hours later. You wake up, you throw all the covers off, and you've got a warm bedroom. And of course, you may not know this if you haven't read the full life saving sleep book, but most chronic insomniacs have a sleep breathing condition. And therefore, they actually need the cooler bedroom temperature. So, what does an insomniac do? They need to take a hot shower or a hot bath before they go to bed, warm up so they're not overly concerned about temperature, and then try to adjust with a cooler temperature in their bedroom.
So actually, that concept of a hot bath or hot shower does help even normal people, correct? Helps them
That
get into deeper sleep earlier, right?
Yeah, that research has been around for decades, and it shows that if you go up higher, then when your melatonin kicks in and your temperature starts to drop, it's conceivable that because you pushed yourself up a little bit higher, now the descent is even steeper. And so, yes, you might go into deeper sleep.
All right. So you mentioned melatonin. We all make melatonin. It's on and off based on light. Give us your comments on melatonin and also use of supplements for melatonin.
No comment. So, melatonin is something, and over the counter sleep aids. And this is some of the work we published in Mayo Clinic Proceedings about 10 years ago. It was called Pharmacotherapy Failure in Chronic Insomniacs. And it looked at prescription meds, supplements, melatonin, everything, all the drugs. This was about 1,300 people that came into our center with that presentation. I've got insomnia. I'm using medications to treat it. And the vast majority were failing the drug. By failing, I mean that, well, no, I'm still having trouble falling asleep, or I'm still waking up at night, or my sleep is still non-restorative. What can you do about it? 90% of those people had a sleep breathing disorder and they didn't know it. And so, what I'm saying to you about melatonin and other over the counter sleep aids, it's a red flag. If somebody is going to a drugstore and seeking treatment for a drug to treat insomnia or to treat what they perceive as non-restorative sleep, and even though those two terms are not interchangeable, they're both quite valid, insomnia or non-restorative sleep, they do that because nobody's had the discussion with them about, well, do you know why you're seeking that? Because their answer would be, well, I want more sleep. Some of them would say, I want more better sleep, but most will say, I just want more sleep because that's just the terminology. That is a red flag, and that means 9 out of 10 of those people, based on our research and other things that we published, 9 out of 10 don't know that their sleep physiology is disrupted. They need a sleep study, and then they need a better treatment than anything they're going to get with that medicine, with one caveat. There are some drugs like Silanor, which is a doxepin derivative. It's got some antihistamine activity. When the inventors of the drug in Dallas and I communicated many years ago on that drug, I said to them, do you know that your ingredients may actually improve sleep disordered breathing? And they said, yeah, we kind of wondered about that because we think some of the people we were testing in our evaluation have the condition called upper airway resistance syndrome, which is a subtle variant of sleep apnea. And so many people who do go to the drugstore, by the way, to pick up these supplements, they have this subtle form of sleep disordered breathing, which unfortunately most sleep centers either don't know how to diagnose or have chosen a path not to pay attention to it. And so that's very problematic because people go to sleep centers and discover that they get a test and the doctor says, well, there's nothing wrong with you. It's all psychological. Go use your sleep hygiene or your medications. I can't help you.
Right. So with Silanor, which is low dose doxepin, of course, that people can't need a prescription for that. Can't get it over the counter. But people do use antihistamines, other antihistamines. Silanor or doxepin is an H3 blocker versus the commercially used over the counter antihistamines are typically Benadryl, diphenhydramine, which is an H1 blocker. And my understanding is that can cause frequent night awakenings. Is that right?
Well, Benadryl, long time ago,
Diphenhydramine, yeah.
was something that was noted to cause leg movements. So it's contraindicated in anybody with restless legs and leg jerks. But again, you have to go back to personally tailored medicine because There are tons of people who use things like Benadryl or any other antihistamine that has a sedating property to it and say, oh, this works perfectly for me. And that just means that whatever is going on with them is relatively milder, whether it's milder psychologically or milder physiologically. That sedating power is enough to overcome some of the things that are going on in sleep physiology or in stress that allow them to get a better night of sleep with it. So I don't look at it again so precisely as you are, because I'm listening to what the patient says about what did that drug do for you? Why did it do it? How long have you been using it? And whether or not you want to keep using it or whether you want a better solution.
Long-term comment on people who are using Benadryl-related products, diphenhydramine. In the long term, as they age, my understanding was or is it's not so good for promoting cognitive good function. Is that correct?
Yeah. Yeah, I've heard the same thing. Well, it's true also of many of the sleeping aids. I mean, the
Correct.
prescription sleeping pills, not to mention many of the psychotropics. And so that's one of the reasons why I'd like to see more people look at, can I fix my sleep without a drug? Because if I can, I potentially have removed those side effects. You may be aware of the recent evidence showing that Ambien actually retards the functioning of the glymphatic system in the brain. So
So that,
basically, if you're using Ambien, you're asking yourself, do you want your dementia sooner than later? Because that's what the drug could potentially do based on that research.
and for our listeners, the glymphatic system is a recently discovered, when I say recently discovered, over the last 10 years, discovered series of channels that allow the flow of spinal fluid or cerebral spinal fluid through the brain to actually help clear the brain of toxins and help us basically rejuvenate. All right,
But hold on, but hold on, but hold on. When does the glymphatic system work best and most?
you'll have to answer that because I don't know the answer.
Sleep.
Well, that's what
And when does it work the absolute best in sleep?
deep sleep.
You got it.
Okay,
So if you're on a psychotropic medication, if you're on a sleep aid, what happens to your deep sleep?
it diminishes, doesn't it?
What if you have a sleep physiology problem? What happens to your deep sleep?
You're not getting detoxified, right?
You got it. You got it. So that's why sleep physiology is so important, because if you do not have the right sleep architecture, which means the first third of the night you're going into delta deep sleep, and the final third of the night you're getting a heavy dose of REM sleep. And we don't know yet the relationship between REM and the glymphatic system, but I'm suspicious that there's going to be a relationship. If you're not doing those things, then the beauty, the glorious nature of what sleep can do for you can't happen. And so again, this goes back to why when you talk to people about sleep hygiene, over-the-counter sleep aids, sleeping pills, psychotropic medications, what's happening is the premise is false. The premise is not helping somebody get to the nirvana, so to speak, of glorious sleep. And the place and the way to do that is by overcoming the sleep fragmentation, which is at the heart of all of these problems. So again, it's a fascinating field. I just got an email today from somebody in Australia who says, I've got to come to Australia and talk to all the doctors there because they're not understanding any of this. I don't know why that is, because the inventor of CPAP is Colin Sullivan and he lives in Australia. Anyway, the
Well,
deal is sleep physiology is the heart, and that's where the action is.
so I think what I'm hearing you say that people can attain glorious sleep.
Not only can they attain glorious sleep, they can reverse cognitive decline if they choose to aggressively work on sleep physiology problems, especially if they're younger. But even if they're in their 80s, they can see some changes in cognition just by reversing sleep fragmentation, which is the nuts and bolts of how you end up with this problem, which then leads to superior sleep physiology. You probably have heard something like, Well, as you get older, you get less delta sleep. You've also probably heard lots of things like, as you get older, you age this way or you age that way. Well, a lot of that research is confounded by the fact that they didn't look at the sleep of the people they were studying. And so we know for a fact that lots of people who get tested in their 40s and 50s in particular, if they reverse their sleep physiological problems, they go all the way almost back to normal. When I treated my sleep disordered breathing when I was 48, my cognition went back to what it was when I was a teenager, or better. In fact, I thought it actually was better because my sleep disorders started when I was 13, and I never knew it till 35 years later. And all during that time, I was suffering from daytime sleepiness. And in my mid 40s, I developed memory problems. I hit 48, started treating my sleep disorder breathing with a dental device, which is the topic of the TEDx talk. I reversed that. And all of a sudden, I had so much energy. I wrote 2 books. I opened up my own private sleep center. I opened up my own private sleep research center. It was full steam ahead just because the energy level was nothing I had experienced in my life, maybe going back to the age of 10. Because when I was 13, I used to come home from school and have to take a nap.
Wow, that's a very sensational claim.
It is sensational, and you should see the people who go about doing the treatment that we propose for this condition. Because if you go to the typical sleep center, they will put you on something called CPAP.
Yeah.
And CPAP is something we essentially banned from our sleep center in 2005 because we knew that it doesn't really work that well physiologically, especially in mental health patients who have anxiety, which of course is pretty much every mental health patient. So when we learned this, we actually in Albuquerque, New Mexico, talked to all of our medical directors locally, nationally, United, Blue Cross, what are some, Cigna, Aetna, locally, Presbyterian, Medicare medical directors. We said, you know what? CPAP isn't going to work in these people. And let me tell you why. But bi-level can work better, and here's why. Every single insurance director in 2005 we spoke to, every single one said, go for it. Just make sure you write in your reports what you're talking about so we know why you've switched them to bi-level.
Explain to our listeners what bi-level is.
So when you have a breathing event for sleep apnea, that breathing event means you have collapsibility of your throat. That collapsibility can be very severe. It's an apnea, or it can be very, very subtle. And it's called a flow limitation event. And between all of these different events of collapsibility, unfortunately, it doesn't matter how severe the events are, they all cause the same problem, sleep fragmentation. Many people have the misguided belief that it's all about oxygenation. Oxygenation is only in a very small minority of patients with horribly severe sleep apnea. For almost everybody else, the problem is all about sleep fragmentation because sleep fragmentation is the same as brain damage. So when your sleep doesn't do what it's supposed to do, your brain is being damaged every night, all night long. And part of that brain damage, of course, is the glymphatic system can't work. So that means more and more waste is building up. And that's why you wake up and you don't feel good. You're supposed to wake up every morning, by the way, jump in the shower and start singing, "Oh, what a beautiful morning," and stuff like that. So if you're not doing that, that means there's something going on with your sleep. You're not supposed to wake up and go, well, after 2 cups of coffee, I feel great. Say, well, that's fine. That's fine if that's the style you operate in. It helps you. Like I said before, I love caffeine. It is the greatest antidepressant ever invented, and it's a life-saving drug. So I encourage people to use caffeine. But if you don't want to wake up that way, you like to wake up gloriously out of a great dream and start singing and have all these creative manic juices flowing, then you want, really deep sleep. So With that collapsibility, what happens is it fragments your sleep. You never get into the sleep stages you're supposed to get into.
Explain what bi-level means instead of routine CPAP.
Right. So with that collapsibility, you must recognize that you can collapse breathing in
Right.
or breathing out.
Right.
That means the PAP machine has to put pressure while you're breathing in and while you're breathing out. And CPAP is one high pressure that more than 2/3 of patients cannot tolerate. Think about it for a minute. If you're in a car driving 60 miles an hour, somebody else is driving, and you stick your head out the window right into the wind and you try to breathe, there are some people who like that. They say, well, it's a lot of fun. But a lot of people go, ah! They feel like they're being smothered. That's what CPAP does. So we learned this in 2005 because we were fortunate to be working with a large contingency of PTSD patients, post-traumatic stress disorder, who have terrible anxiety. And they hate CPAP. And we put them in the lab and we do the routine. Well, just try it. Maybe you'll get used to it. And we kept looking at them and looking at them saying, you know what? This doesn't look right. There's something wrong with their breathing when they're on this CPAP machine. It just doesn't make any sense. So we switched into bi-level, which means two pressures, bi-level, two pressure. When you breathe in, it's high and it feels really good. But when you breathe out, it now drops the pressure.
It still keeps you open. Still
It
keeps the airway.
still keeps you open. And they discovered this in 1994 that you can keep it open with lower pressure. So why are you giving people higher pressure? In 2005, when we discovered it, we said, this is incredible. And people would come to us and go, well, this is remarkable. Like, why didn't I get this? I said, well, because we're stupid. That's why. And now we figured it out. This is the machine we want everybody on. By 2010, everybody was on a device called auto bi-level. And then by 2012, we learned about something called the Cadillac, which is ASV. And ASV is the most advanced bi-level machine on the market. And we found that 1 out of 3 people in our cohort needed ASV, and 2 out of 3 needed auto bi-level. And these are very advanced algorithms. They're actually measuring your breathing while you're breathing. And every third breath, they're changing the pressure to accommodate your need based on the collapsibility it's detecting, because what it's doing by having that mask on you, it's actually measuring your breathing all night long.
Why shouldn't everybody be on ASV?
So you have touched upon the area that I am literally the most famous for in either the world or at least Reddit. And that is, I have espoused that if they put everybody on ASV, over 90% of individuals who went on a PAP machine would immediately love it, would immediately adapt to it, and would immediately get benefit from it. Do you understand what happens in the CPAP world? They actually say to the individual, well, you have to use it for a while to get benefit. And if you've used it for a couple of months and there's no benefit, well, use it a few more months. That's dead wrong. And unfortunately, when I say that word, I'm not joking, because so many people who need PAP quit just after a week or a month or 2 months. And you probably know virtually all cardiovascular disease patients need to be on PAP therapy. Fortunately, the cardiologists are really getting in sync with sleep medicine and ordering tests. And some of them are getting in sync with the idea of bi-level devices. But ASV is controversial because of a very poor research study that was published in, of all places, the New England Journal of Medicine almost 10 or 15 years ago, which was completely bogus, never should have been published, should have been retracted by now. That it hasn't been, I really don't understand. Many other papers have come out since then proving that what they said was wrong. ASV does not cause premature deaths, but ASV may not be the right thing for some people with really severe heart failure. That's not the largest majority of people who are on a PAP machine. We've put ASV on thousands of mental health patients. with PTSD, opiate users, some with mild congestive heart failure, tons of insomniacs. They love it. I'm on ASV. I've been on ASV for over a decade. It is an absolutely miracle working device. And it's just so sad that so many sleep doctors are not aware of this and think that it's controversial.
Well, it sounds like everybody has a sleep disorder.
No, it's
That's
not true. It's about two out of, when you look at the adult population, like if you go into Walmart and you walk around, you look at people, look at their facial structures, look at
right.
their eyes and so forth. If you said that's a representative model, you'd say, I think anywhere from 1 out of 5 to maybe as high as 1 out of 3 of those people, they're normal sleepers. So there are people out there that are normal sleepers, but they're so normal, they're in a different world. They don't understand what we're talking about. These are people that do
Waking
the
up
amazing.
feeling, they're
Oh,
waking up feeling glorious.
no, better than that. They just get into bed and they go to sleep. They
Right.
sleep all night long, no breathing symptoms. They never wake up at night to pee. You know that sleep apnea causes people to wake up at night to pee through the release of a diuretic. They have tremendous energy during the day. They almost never drink coffee. They don't even know what coffee is. When somebody's drinking coffee, they go, why are you drinking that? What is that doing for you? And they go, oh, well, it gives me more energy. You say, oh, I guess I don't need that. So a normal sleeper is a very different type of individual.
But
And
they're rare. Sounds like 1 out of 5.
right, 1 out of 5, maybe 1 out of 3,
Are,
maybe, go ahead.
are some of those people overweight or obese who are good sleepers?
It could be, but very rarely.
Right.
Most of them are relatively fit, but they may not even be interested in physical fitness. They
Right.
just go about their work so much, that's their physical fitness.
Because, in this country, of course, probably 2 out of 3 people are either overweight or obese, and that's a confounder for sleep significantly.
Well,
Okay,
confounder,
so
yes and no. It's confusing because fat tissue does go into your airway and make your sleep disorder breathing worse. But one day they'll do the study that shows the largest majority of obese patients probably have upper airway anatomy that predispose them to developing the sleep apnea at a very young age. And so these co occurring morbidities is what really was part of the obesity. They didn't just get fat.
right,
They had sleep apnea, which did all kinds of strange things to the metabolism. And then they started overeating, and then their sleep apnea got worse, and then they got more obese.
right.
It's a horrible thing. Are you familiar with the ACE study by Vincent Felitti?
No.
You would love that research on obesity where it shows the truly horribly morbidly obese all suffer from childhood trauma, every single one of them. And that he discovered that you cannot treat them with anything unless you also treat them psychologically. His research has been around since 1990s. I got to meet him in Albuquerque, and we were basically on the same page because I was at the time researching a book and putting in it what we call emotional processing theory as it relates to insomnia, which is a very important topic in its own right. But that technique is what he was talking about when he would be treating these people that were 500 pounds and they'd go on a liquid fast diet and they'd lose 300 pounds. And then he'd see them again 2 years later and they were 500 pounds again. And he did the research, and virtually every one of them, childhood trauma had turned them all into emotional eaters. And so they could never really conquer obesity because that part of the problem was never addressed.
All right, we have 2 other things that we got to talk about. The first is I want you to talk about sleep physiology, which you mentioned, but it sounds like most of your patients who have sleep physiology problems need ASV.
Well, sleep physiology means something isn't right with sleep architecture. The most common fragmentation is either sleep disordered breathing, but once you get over the age of 60 and unfortunately that's what I did, you end up with restless legs and leg jerks. And that's actually much harder to treat than sleep disordered breathing.
Right.
So I got that fantastic result for ASV for 20 plus years. But the last 5 years, I've had to struggle with ASV and trying to treat restless legs and leg jerks. There are other people where there's other contingencies or out there research protocols talking about other hyperarousal phenomena that could cause sleep fragmentation. And we don't really know what all of those are yet. And you could say, well, do those need medication? Maybe, but maybe something else. But anything that doesn't let you go into deep stages of sleep means you're going to end up having sleep fragmentation as the cause.
Okay, so for our listeners, stages of sleep, 4 stages of sleep plus REM, right? Cycles of sleep, 3 to 4 a night, right? So stage one, doze, stage two,
Better, a better way to think about it is that stage one and stage two will take care of themselves.
no
What
problems.
a person wants to think about is one question: how deep did I sleep?
Right.
And if you get people to think about it, they're going to go, well, how do I know that? I'm asleep. Well, you know it because you're supposed to feel great. And if you don't, that's question number one. Question number two: how much dreaming do you do during the night? Because if you're a normal sleeper, you're going to dream a lot. You're going to remember your dreams. You're going to enjoy your dreams. You're not going to have a lot of nightmares. You can have some bad dreams, but you're going to mostly have good dreams. So it's really about deep sleep, first third of the night, REM sleep, more in the second, final third of the night. The middle is a mixture of things, but you don't wake up in the middle of the night to pee. If you wake up in the middle of the night to pee, go to my website, barrykrakowmd.com. Look at the first video called Nocturia, 5 minutes, and it'll explain to you why, if you're waking up at night to pee, the answer is probably not you're getting old or you're drinking too much water, and it may not even be your prostate or your bladder. It could be just sleep apnea.
So the apnea wakes you up. You have a higher level of awareness. You say,
Mm-mm. Do you know what atrial natriuretic peptide is? ANP.
yeah.
So ANP is the one from the right atrium,
Mhm.
not the BNP. The beta, is that what's called beta natriuretic peptide?
Mhm.
So atrial was released due to the buildup of pressure from trying to breathe. That diuretic releases from your heart and goes to your kidneys. You make more water during the night.
Well,
And
you're also flat, so you have an increase in return to your heart, which contributes to that.
far more, a normal sleeper
Hmm.
can drink a quart of water at bedtime and not wake up to pee.
Okay. Now
Right?
the
So
other thing,
how'd they do that?
exactly right. I mean,
So no, you're supposed to drink water all the time. And why would you want to become dehydrated during the night when you're sleeping? Why wouldn't you want to drink a lot in the evening to hydrate yourself? Because you're not going to be drinking during the night. But there is a reason you wake up to pee that's largely due to the fact that your kidneys are sent a message: make more water, because this is giving you a false fluid overload signal in your heart. And when the heart muscles distend, it releases the diuretic, it goes to the kidney. It's much more important than drinking too much water, which can cause a problem for sure, or prostate or bladder, which can cause problems. All I'm saying is, I've seen all of those complaints. And yet, those same people come into a sleep lab on the very first night, they're on a PAP machine. In the morning, they go, why didn't I wake up to pee last night? I say, well, because you're on a PAP machine. And we reverse that whole cycle. That's how powerful this is.
and you wouldn't get that necessarily from a dental appliance.
Mm-mm. Absolutely, you can get it from a dental device. I got it from my dental device in 1998.
Right.
I was going to the bathroom 2 to 3 times a night. And then in 1998, used a dental device, went down to zero.
Well, that's fascinating. There's something else at work too, though. As you age, you make less antidiuretic hormone.
Correct. Correct.
So you're more likely to make more urine and to want to pee. I mean, I've seen strategies where people actually are given vasopressin to
Right.
suppress their likelihood of needing to get up to urinate.
And virtually every one of those patients has never had a sleep study.
Okay.
But that's okay, because if it works, that's great. But you don't want to miss the cardiovascular problems that are caused by sleep apnea, which produces endothelial dysfunction, oxidative stress, pro-inflammatory states. And just for the record, Johns Hopkins researcher, clinical expert John Samet said untreated sleep apnea is the equivalent of smoking a pack of cigarettes a day. So if you want to smoke a pack of cigarettes a day, don't treat sleep apnea.
That's quite an endorsing statement for
Jonathan
improving
Samus,
your
one of the most
sleep.
famous, one of the most famous epidemiologists at Johns Hopkins, said that 20 years ago at a sleep conference in front of 5,000 people, and people couldn't believe it, but it's true.
Well, wow, you've given us a lot to think about. So,
A lot to sleep on. Is that what you're saying?
something to sleep on. We talked a lot about a lot of complex physiology that is probably somewhat overwhelming to some of our listeners. But if you had to deliver one single message today, what would that be?
Person needs to pay attention to the quality of their sleep. It's all about sleep quality. It's got almost nothing to do with hours of sleep, although there are rare exceptions. Sleep quality is where the action is. And let me put in a small plug for my book, in that if you think you have a sleep quality problem and the chances are high at sleep disordered breathing, there's at least two big sections in the book, Life Saving Sleep, on conservative treatment of sleep disordered breathing. You can use nasal strips, nasal dilators. You can do nasal breathing treatments. And over 70 or 80% of the people who do that will say, you know what? I'm already sleeping better. Within 2 weeks, they'll go, I'm sleeping better. Like, oh, this must be real. I'm sleeping better doing this really simple steps. Then the question is, what do you want to do more about it? Anybody with blood pressure problems, cardiovascular disease, or any kind of cognitive issue absolutely wants to get a sleep study to evaluate sleep quality.
So let's talk about for just a moment. I'm hearing if you can't tell me that you're satisfied with your sleep and you wake up feeling refreshed, if you can't tell me that, you should have a sleep study. So the sleep study that we want can be a home study, or you wouldn't go for that.
Well, here's the deal. The way medical system is working right now, there's no way around it. It's going to be it's going to be a home study. You'd have to learn special negotiating tactics to get an in-lab study, but it can be done, especially if you've got a very complex case. And you as a doctor can say, no, I don't want a home study. I want in-lab. I want to see the REM. I want to see the delta. I want to see all the patterns of sleep fragmentation. But you can start with a home study, because if you've got an obvious case of sleep disordered breathing, it's going to show up. The problem is when that study comes back negative, then you've got to be willing to say, well, okay, came back negative. You know, I heard that if your home study comes back negative, you just purchased a ticket for an in-lab sleep study. And you've got to find a sleep center that will agree with that philosophy, which was the original philosophy about
And
home tests.
an insurance that will allow it, right?
Insurance was supposed to allow that too. That goes back almost 20 years, that yes, if you not failed, if the test was negative, oh, then you're a candidate for an in-lab study.
Well, this has been great. This has been a terrific discussion. And again, I think the message to give our listeners is that you should wake up feeling refreshed and, in your words, glorious. And if you're not, it's something to talk to your physician about as to whether or not you should have a sleep study, and of course, what kind of sleep study. So this is very, very, very enlightening, and you're very passionate about it. But I should have known that, because you're passionate about most things.
Can I give one caution?
What's the caution?
People hear this kind of stuff and think, oh, I got to get off my meds. I got to get off my meds. Please, please don't do that fast. It's very important to understand that if you don't want to be on your sleep meds, learn all about sleep physiology, do what you need to do, and take your time and work with your doctors to get off your meds slowly, gradually, and safely.
Thank you. Great to have you. This has been a terrific discussion, as I said. Thanks to our audience for listening, and thank you to the Columbia Association for sponsoring Finding Your Wellness. You can listen to all of our podcasts from Finding Your Wellness by typing into your browser findingyourwellness.podbean.com. That's findingyourwellness.podbean.com. This is Dr. Harry Oken.
Thank you for listening to Dragon Podcast. You can find this episode and all other Howard Community College podcasts available for your listening pleasure on all streaming platforms, as well as Podbean at podbean.com/Dragon Podcast. Thank you for listening.